Back live.
Okay, now
We are live. We're back here, Senate Health and Welfare, and we've had some technical difficulties, but we are able to now go through with Elliot Fisher's his slides. So for the record, well,
Thank you. Lovely to be here. My name is Elliot Fisher. I am a professor at Dartmouth and interested in health policy and trying to help our state do better. So the second slide of my presentation highlights the gist of my arguments. You need a healthy workforce to have a productive economy. U.S. faces a rising burden of chronic disease and premature mortality. It's getting worse for decades. Healthcare is, of course, essential by helping us keep healthy. But much of what we're spending money on in healthcare now is largely waste, and some national data show that. Unnecessary healthcare causes harm in a bunch of different ways, both to individuals in terms of our pocketbooks, but also to local economies. And, as I was asked to think about healthcare economics, I went back to school a little bit to try to learn more about the economic impact of rising healthcare prices and healthcare spending on local economies. But I think the final answer is that we can do better. And that's why I was excited to listen this morning to hear about the response to the outline, which I think has a lot of really promising ideas in it. But let's move through this and then we can come back. The third slide just shows the data on what's happened to life expectancy. We are falling behind other countries, and within this country, within other countries, the differences across different regions is like four years. Within the United States, it's 20. The widening disparities between the least and best well-off places in the country. Spending, we've also gone worse, although we have worse results, we're spending twice as much. So we don't have as productive a workforce, but we're spending twice as much as our comparative countries on healthcare. I went to slide 4 as we did something disappear. People okay. Oh, we're back to our favorite screen.
do it again.
I'm just following.
We're okay.
Chair's
We're
orders.
still on. I just wanted to be
Following orders.
We'll be good.
Yeah, that's what I'm trying to do. I think it needs to
If you
just
push
work.
that top, they usually come in and push that top camera thing down.
No.
No.
I don't know what was wrong with that view. A lot of
Nothing.
a lot of
I'm
communities
hoping we
like
can
that
get
view.
the screen back.
It's up to you.
My, okay, we're good.
Yes, there.
There we go. Sorry.
Okay.
On slide 4,
Not to worry.
and the title is,
Slide 4, the title is Health Economics 101, Healthcare Spending Per Capita Twice That of Other Developed Countries. The subtitle. And I think it's fair to at least consider the possibility that all of that extra spending we do can be considered waste if other people can do well. It's a big number, but I think our opportunities are really substantial. And then you go to slide 5.
I do have a question there, but how is it held constant for investment by, federal level government dollars, or that just overall spending?
This is total healthcare spending.
Okay,
So this is federal,
everything.
commercial, private, person level spending, everything. Yes.
Can I just share musings on a Friday?
Yeah.
I appreciate you being optimistic and saying that we could do better. But as you know, we have a for-profit healthcare system, and I can't reconcile in my own mind how those two things can coexist, because as long as we profit off of the, the poor health outcomes of people, it just doesn't make sense to me. So I'm trying to keep an open mind, but it's hard. I'm sorry.
You're Canadian?
Yes.
Well,
American Canadian.
My
Canadian
grandchildren
American.
are Canadian.
So anyway, sorry.
no,
We live
I
close to
I
Canada.
don't think I think it's a great question. I don't see how, and it's really building on Elena's piece. How you can have a healthcare, how you can have people deliver care without a practice, for example, having to maintain a margin. You know, so that I have to have, or a hospital having to have slightly more revenue than what their costs are so that they can reinvest in their plans. So I'm also, I mean, I'm happy to share, I don't want to get too far down in the weeds, but I'm happy to, I'd love to have a longer conversation. I think there are ways of creating a system that builds more on competition in ways that squeeze the profit out of the system to the extent that we can.
No, I'd love to learn
We'll
more
talk
about
about
that,
that.
yeah.
That's,
Next.
Yeah.
slide.
If you turn the TV on for half an hour on any night, the pharmaceutical ads are like mind blowing, just.
There are some really interesting.
then you see.
So I'm gonna suggest this.
Right.
We've got a lot of good conversation and we've got another. So,
I'll do my best.
Bill, so we're just gonna go on for another 15, 20 minutes.
So I think the fifth slide, which shows Vermont spending compared to our neighboring states,
Yeah.
is a better example of the magnitude of potential waste that we might be able to reverse, because it's only a few years ago that we were all spending the same amount. I think that's a fairly, to me, it's a worrisome picture, but it's also a hopeful picture because it says that, well, these things happen. How can we reverse them? The next slide, slide number 6, is I think a pretty important slide, and I want to walk you through bits of it. You know, yeah, these are two evidence-based attempts to figure out how much waste there is in U.S. healthcare. They're both pretty big estimates. 20 to 30% of the, 20 to 33%. If you look at Thorwick and Akbar's number, or you look at the slightly more recent one by Will Frank and his colleagues, 20 to 25%. Those are big numbers. Everybody, we'd love to have that money back in our pockets. And I think the numbers are bigger in Vermont because if we walk through this, I think there are places where I would say we have a much bigger problem than is represented in this national data. I think it's, if you look at the top category there, these look like small numbers, but this is failures of care delivery. This is where we're not delivering great care. We're not controlling people's blood pressure. We're not helping them manage their cholesterol. We're not helping them stop smoking. We're not managing their chronic conditions effectively. So they progress in terms of their illness. So some of the examples I shared when I was last here of systematic efforts to improve quality, whatever those are, and I think we can talk about them, strong primary care, integrated delivery, like Kaiser and some or the VA, which in fact has an incentive to try to keep you healthy with them. And the VA is an amazing example of care coordination and emphasis on primary care. So I think that first category, we can do better there. And I think we'll want to talk about how to strengthen primary care. Failures of care coordination, this is where you end up going to 6 different specialists and they all have different opinions, and then you go see them again. It's just failures of care. There is substantial overtreatment in the United States. We know that. The next administrative complexity, we heard all about it. How many different, and this is the comparison again to Canada. How do we have to have an average, the average physician practice deal with 10 to 15 different contracts and 15 health plans, each of which you're negotiating has slightly different rules. This is extraordinarily wasteful, and doctors hate it. And then I think the thing that makes us exceptional right now in Vermont is pricing figures. Where we've seen just the escalation of prices from the medical center that are really, I think, the major driver of that higher.
Yeah, I mean, we did have a bill last year or last session that nobody liked, but it did have significant role for us, or transparency of contracts to try and align those.
Yeah.
Nobody liked that.
What I appreciate hearing a fair bit of support for even from John Calmer, was we have to figure our way out of this. We have to figure out what's actually going on, the total, where the money is, how do we find the drivers and go after it. So the next slide.
Can I
Yes,
ask,
please.
can I ask you a favor?
Sure.
Now, this is gonna interrupt our whole brain, but we do have someone here who needs to leave.
Sure.
To
So I
get,
step aside?
and so if you step aside, we'll come right back to this slide. That would be helpful.
I can probably remember where I am.
We know where you are. We know where we are in two ways.
Happy to do
Dr.
so.
Keegan,
Totally.
welcome. Thank you for being here and your patience. We appreciate it.
Thank you, no problem.
And so we had Dr. Clara Keegan here to talk briefly, comment on S-28 and act relating to certain legally protected healthcare services. It's a bill that we are very interested in passing out of here as quickly as possible, but we need your comments.
Sure. Hi, I'm Claire Keegan. I'm a family physician. I provide general primary care for all ages, and that does include abortion care in my practice in Chittenden County. So I wanted to talk to you a bit about the safety of mifepristone and misoprostol for medication abortion, and specifically that it is also safe for providing through telemedicine. It doesn't require an in-person visit. These medicines have been in use through FDA approval since 2000, and with the pandemic, there was a pause in requiring an in-person visit. So we have data from those years as well. In terms of efficacy for causing an abortion, the combination of pills is about 97 to 98% effective. There are very few reasons that it's not safe to use them. Those include adrenal failure, kidney failure, liver failure, none of which require a physical exam. We determine those things by taking a verbal history. We do not want to use them in people who have a high risk of bleeding or who have who are on a medicine that causes bleeding, because bleeding is the most common complication. The medicines cause a miscarriage. So just like with a spontaneous pregnancy loss, the highest risk is of heavy bleeding that might require transfusion or a procedure to empty the uterus. So if somebody has those bleeding risks, we recommend the procedure rather than the medicine. We also want to make sure the pregnancy is in the uterus and is not an ectopic, which is about 2% of all pregnancies. These medicines will not treat an ectopic pregnancy. So understanding that there is a risk of ectopic in any patient, we do screen for things that might put the patient at higher risk of ectopic, which include a prior history of ectopic pregnancy, an IUD in the uterus already, a history of pelvic inflammatory disease or a history of surgery on the tubes. And those patients who are at higher risk, we would recommend an ultrasound before receiving the medicine. There are cases, even when ultrasound is available and we see people in person, that the pregnancy might be so early that we can't even determine if it's ectopic, and it's not unsafe to give them mifepristone. It just won't treat the ectopic. So the follow-up is important regardless of the way that the patient accesses the medicine. The follow-up to confirm that the pregnancy has passed is very important, because some of the reported complications of mifepristone are in patients who had ectopics and then went on to rupture, which is not a failure of the medicine. It's just something that can happen in any pregnancy. I think some of the question is about what we would call asynchronous care. So when I see a patient in person for mifepristone, it's a conversation. I don't have to do any physical exam at all. So that could also be performed through video or by telephone, which is what happened during the pandemic. And now that we're trying to create access for people who are in restricted states, people can actually do this, what we call asynchronously, which means they fill out a form through like a medical portal. And then the clinician doesn't have to be in active conversation with them at the same time. They can come back to it a few hours later, answer any questions. And so they can sort of message back and forth rather than actually have a conversation. And that is equally as safe as having a conversation or seeing the person in the office. And I would be very happy to take any questions. There's a lot of clinical information that goes into determining that this is a safe process. So happy to explain anything further.
Well, thank you. This is a part of the bill that we haven't had testimony sufficiently on, and so your testimony helps greatly.
Sure.
That's good. So questions committee on this. We did go through this during the pandemic, for those of us who went through the pandemic on Zoom and on telephone, and we did make provisions for the care of folks seeking abortion. So your testimony is helpful. It's not so esoteric in the medical world.
Right.
Right.
No, that was really helpful.
Great. And, I have plenty of information that can be provided.
Well, I think it would be helpful for us to have your testimony in
Absolutely.
writing and then some backup data. to
Yeah, of
support
course.
What you're saying.
I'll pass on a link. This is like a flow chart, a flow sheet that helps people, like if you're seeing someone through telehealth, what are the questions, what are the things you need to consider? What do you do at each step if they have an answer that
Okay.
raises the question?
And then whatever, it would be good to have this electronically, so. we can-
Absolutely, yeah.
That'd be great.
Yeah, I have links to it in the testimony.
Oh, great.
Yeah.
Thank you. Thank you for your availability. I know you
Absolutely.
have been
Yeah.
your patience.
Patience at one, but I've got plenty of time to get back. So
That's
thank you
good.
so much.
All right, good.
Thank you.
What do you need?
So we actually,
The Stephen West.
so this is good. We actually, we talk a lot here.
Yeah, I recognize it.
We talk a lot about healthcare policy and the big umbrella, but it's nice to have the boots on the ground.
Absolutely.
Yeah,
Yeah, happy to help.
thank you very much. Okay.
That's a Stephen.
Huh?
He's wearing a Stephen.
She is.
Yes. Oh, he's a very well known. Oh, it's so beautiful.
All right, back to it.
Back to waste.
Now we're back to,
That's important care.
yeah,
That's care we want to make sure.
that is important care for people. They get so involved with belief systems and cultural differences, but for a large cohort of patients, it's.
So just to sort of summarize slide 6.
We're on the slide that says the economic impact of healthcare harms, correct?
Yep.
Yeah,
Sources and ways. Actually, so we'll go to the direct harms.
okay,
And I think the major point of this table, before I go to the left-hand side to talk about the harms, is that a lot of what you're talking about in the design of this bill is set up to try to address each of those elements of waste in the United States healthcare system. And I think, so I'm excited about what you were contemplating. In terms of the harms, if we don't treat people well, we're going to progress, bad health outcomes occur, like either failure to deliver needed care or overtreatment, both can cause harms, and or simple bad care, I'm sorry, again, your story about your brother. Bad care happens and we should be able to do much better. And that is a tremendous opportunity to improve outcomes. The financial harms, we've all heard about from, the Act 167 engagement, from all of our constituents and your constituents. Most people, 74% of Americans approximately are afraid they're not going to be able to afford healthcare or the next visit to an issue.
well, it occurs to me that, you put this down, 74% of Americans, and the cohort is growing because of long-term care
And
demographic.
Well,
Yeah, other things.
Yeah.
Yeah,
yes, I mean, it's everybody who should be.
Pretty
afraid
much,
of it.
yeah.
But, and that is another element of what I think you build, is a more resilient system.
it is. People keep saying, don't you want to have a reserve fund? Or what are you going to do for healthcare for the federal? We are doing it, I think.
Yeah.
Somewhat.
I think I've heard there are other conversations going on about how to move more
Yeah.
quickly to figure out how to build resilience in the system, which this bill can address directly, but the conversations that you catalyzed are forcing people to think about it. And it happened the last time I was here
Yeah.
for both committees.
The emergency.
Yeah, think about how we're going to plan for it. What I was unaware of until a week or so ago when you asked me to think about coming back and talking about this was really the impact of rising healthcare costs on local economies. And Zach Cooper, who is really one of the most noted economists focusing on trying to understand monopoly pricing, had published a paper just in December. It's still a working paper, but I believe I sent it to you. So if everyone wants to
I
read,
think you sent it to me.
yeah.
We're gonna have, we're trying to get him in, so we'll
Right.
definitely have a paper.
So I'll try to summarize his. Let's see what Senator, what slide you have? I think I got my one.
The one after farms,
No, yeah, it's the one that has
farms,
the
local economies, yeah.
Harms local economy. That's the one I want to see. You know, I've got easier for you to read this bigger one. This, my glasses. I've got it right here. You're very kind. Thank you.
Perfect.
So I think it's a really important paper. It applies not just to prices, it applies to the increases in volumes as well. When you increase spending, it's essentially a payroll tax. It has a lot of downstream economic consequences. Payroll taxes, you know, the economists call it dead weight, but what you see is summarized on the right-hand side there. You know, a 1% increase in healthcare prices causes a 0.4% decrease in payroll employment by private employers. Because that's only at the employer level, he also does an analysis at the county level where he summarizes the impacts of the mergers, which are used to estimate the impact. A merger is a way to estimate the impact of a 1% price increase, and you do it in a way that gets you out of a circular loop of causation. So the very persuasive methods of doing this that he's come up with. But the county level impact is, you know, 0.2% decrease in labor income. Well, but that's a 1% increase in prices. And what does it mean? Yeah, it's a huge local impact. And taxes, and taxes go down because people have lost their incomes. So and I guess in Vermont, state income tax receipts should be 0.1%, but it's, you know, you're not only, people are less healthy, but you're also leading to adverse economic impacts, which hurt our local economies and make it harder to recruit new businesses to come to, you know, to come. Healthcare's made it expensive already, but now the positive increased costs of insurance discourage businesses from moving here. You know, I think the last three are, you know, obviously things, most of the stuff always falls on low and middle income people. The adverse consequences. They did find, you know, additional deaths due to suicide and overdose from just the rate increase in prices within the United States. So, you know, it's a serious problem. Let me go back to mine. You said if you want to go to that. No, I think I want to go to, if you want to go to the we can do better, slide 9. So I was very lucky early in, 15 years ago to be part of this Rethink Health initiative that brought MIT folks together to try to develop the best possible simulation model of how could we improve health and healthcare in the United States. It's, and these are very smart people. We exclude myself from that category. But over 2,000 papers, I think, reviewed to synthesize the evidence that we were using to put in this model. And it looked, yes, over a 20-year period. But I think you have to think of the long game right now. The interventions that are included in the model kind of correspond to what we've been talking about: better care delivery, care coordination, increased investments in primary care, shifting to global payment for provider organizations, taking some of the savings and investing those in the things we know communities need, which is more better education, adequate housing, adequate food, the vital conditions that are essential to people doing well. And as I mentioned, the way you get this cycle to work is that you take some of the savings and reinvest them. So coming back to the planning that we envision in this bill, if you think about, we're going to try to achieve some savings from reducing hospital expenses, avoiding unnecessary hospitalizations, then some of the possibility there is that you can take a share of those savings and start to invest them in the other things that will make people more healthy in the long run. And I think that's envisioned in the Acts 167 report that you guys prompted, and then now just moving forward. But this is intended to show you the long-term impacts of doing this in a way that puts this portfolio together and says, we really can do better. You know, compared to not doing any. Healthcare costs went down by 15%, would go down by 15%. Burden of chronic illness would fall by almost 20% for the population that has a chronic disease. Poverty would fall by almost 20% because people can now work because they're not sick. And the biggest number in the whole model is this gain in worker productivity. This is the growth in wages in a local market. This is measured as wages in the local market. That are produced when people that can be produced when people are healthy.
Supersedes the loss of economy that we're looking at the previous slide.
This is actually, it's rather than look at the harms.
Yeah.
We're going to look at the benefits of reducing costs from investing the way we should to keep people healthy, reduce complication rates, etc. Any questions about that?
Well, the simulation, sorry.
Yeah, no, please.
The simulation model that they're contemplating here, does it reflect or echo what we're trying to do in our committee bill
I think so.
closely, or?
First of all, it is a simulation.
Yeah.
It's simplified. You know, the broader, it is a fair bit of these gains come from investments that keep people healthy or help poor people become healthy, or have healthier lives. So it is in addressing the clinical causes of poor health, like that's the primary care piece. But it's also about early childhood education, social services that prevent adverse childhood experiences, training so that people can go back to work after. So I'm happy to share the article with you. The model, I'm just about to teach it to students next week. It's inspiring. It's been used in a bunch of communities across the country. Probably 20 different local implementations of the model. It can be used to bring members of a community together to talk about how do we as a community or a state decide that we want to work, what do we want to work on? It was used, the first time it really got a serious test was in Atlanta, where 120 people came together over the course of 4 hours. They came in, each giving their opinion about what you should do to fix and make healthcare better. And of course, everybody had primary care docs. What do you think they said? Primary care. But anyway, it's true. It's true. But by the end of it, other people weren't that supportive of that idea. By the end of the morning, they walked out with 4 work groups that have been sustained as part of, I think it's called Healthy Atlanta. To try to put in place the major pieces of this. How do we invest in improving the health of each of our communities? How do we look at the healthcare system and try to take the waste out and improve quality?
So did they look outside the healthcare system at things like paid family leave and universal pre-K and stuff like that, or was that not in
No,
there?
that's very much part of it.
Okay.
I don't think universal, I don't know about paid family. The specific interventions may not have been.
But social determinants were
social determinants were the major, the major driver of the big gain. That big gain in productivity is the story I hope my students walk away with next week. Is that if you there are ways of investing in on the healthcare side where you get rapid savings within a couple of years. If you invest in the most powerful intervention is to invest in care coordination, which is a label or a set of ways of enabling primary care to make better referrals, to avoid unnecessary specialist treatments, to avoid unnecessary stays in the hospital, kind of with some of the things that we've been talking about. And those you accrue savings very quickly within a couple of years. And that's why I think, anyway, but you take some of those savings when you have enough of them to start to do the other activities that lead to longer term and sustained improvements in the health of your state or the health of your community. Does that make any sense?
Yeah. Thank you.
And the people who run Rethink Health, we're talking next week with the Terrell Fund and Ripple about seeing what we can do here with the model or with this approach to community-based motivation to try to get us on the same page towards that.
That was a huge part of the Act 167 from 2022. I mean, really moving medical and social medicine and treatment programs together.
It's very powerful. It's really expensive to do the social investments.
Yeah.
And so what you're proposing for the board and the planning is to try to squeeze the balloon or whatever the phrase I want to use.
Get a smaller balloon.
Get a smaller balloon. I think that was how I ended my last conversation with you. Because that's where the money can come from without increasing taxes to do the things that that you could then afford to do. And so that's why I'm not.
Thank you.
And I've tried for 40 years and, I haven't made a difference yet. So.
Well, the time will come. So
That's why I think Vermont is such an important opportunity, because I think we can be, and we've just gone through this horrible experience with cost, but imagine if we would do different. What?
Go ahead.
I see on here is it says an evidence-based simulation model from MIT to Rethink Health. How do we get a hold of that?
The model?
Yeah.
I can give it the login if you want. That's not it.
Yeah, no, go right ahead. We'll put it on, can we put it
It's,
on one?
you have to-
It's an individual.
I think the easiest way to get there, if you, I can send it. I'll send you the link to, if you want to play with the simulation, you send it to Keith, or you can.
Yeah, send it to Kiki. She'll send it
Okay.
around to us.
You're
Yeah.
also welcome to join the class. That's when we teach it. We can teach it to Dartmouth people both next week. You guys are probably busy, but I think it takes a little while to learn how to use it. But the article, I'll send you the article, which sort of explains what's included in the package and what, and Bobby Milstein, who still teaches this, would be available to come up to teach, like, if you wanted legislators to experience it. Best to have an exercise developed specifically for you. In a couple of hours, you can get the experience of seeing it.
What is the model based on?
It's based on.
Where did how was it generated? When did it happen?
It was built over about 20 years.
Yeah.
Starting with some basic individual health models. There are simulations of what happens with
Yeah.
heart disease, built up to CDC models, which are about predicting the impacts of diabetes and other chronic conditions on life expectancy.
Yeah.
And then this one brought in other elements of the healthcare system so that we could understand all of the ways that healthcare can be wasteful. And what we learned recently about the possibility of improving efficiency, like ACOs.
And we do have someone in our state who worked for a while in Massachusetts on some of that work, and I think she did a lot of that. We're going to try and get her in. Payment models.
Yeah, the payment models are.
Yeah.
Some of us believe payment models are how to fix this, but they gotta be all payer.
Right.
As we just heard.
You're right.
That was other questions?
Where are
we? Already mine.
We're on slide, are we on slide 9 or 10?
I think,
I think we're done.
I think we're done.
Oh my
I ended
God,
on
we're
this.
done. We had, oh, there it is.
You fixed it.
We did it.
This will require evaluation. No, the last slide says this will require evaluation, what the specific drivers and ways. Planning, who should do what, regulation, where it's needed.
We like that. So wow,
I'm sorry that took so long.
no, it did not. It was
Good.
perfect timing. I mean, Elena, are you still there? Do you have anything you'd like to add at this point or join in or?
I'm here. I'm, I'm happy to answer questions too, but I feel like I would just echo a lot of what was said today and just thinking about creating a process that allows us to iterate and learn until we can get it right. And we have to hit the prices and make sure our resources are going to prevention. And so, yeah, I think you've heard all of that over and over again, but
So there are two asks. That one is, or the ask of you in terms of the incentive piece that would be critical, I think, for us to improve it. And I guess the other ask, and it's for both of you, and it's something you mentioned, Dr. Fisher, is that we know that we could be in a significant crisis, knowing what Washington is doing to states. And so the question is, what emergency steps could we take that will buffer the effects? What will make us resilient in the short term or even the longer term? I know we're trying to do that here, so just thinking about that.
Well, since our last meeting, really, so this idea of how can we be more resilient, how do we respond to this emergency constructively? I've spoken with, Brendan Krause, I've spoken with folks on the board. I understand that there is some interest in trying to think about sort of what's our emergency response team look like?
Yeah.
I think those conversations are ongoing. I understand there's interest in doing it in AHS and at the board, our senior board members. I think, if you look at my own, now I'm stepping to the kinds of things that I suggested as illustrative to my friends everywhere that I've now made over the last 2 years. Brendan and others, and Brian, and Secretary Singleton, I would think about it as what's the dashboard we need to know who's most vulnerable. We just lost a clinic last week. In primary care clinic. What are the days cash on hand of everyone, and how quickly is that changing? I think you need to sort of stay on top of it. So one is, what's the dashboard? What's happening to emergency room visits? What's happening to, so I don't know what the dashboard is, but there should be a concerted effort, just as we had in COVID, to figure out what we need to know to respond in time before we lose a major provider or before, a subgroup of patients is suddenly hurt really bad.
How do we respond?
How do we respond to that? Please. So that's the dashboard.
Well, here's the thing, we don't know what we don't know.
Right.
But number
Right.
2, we don't know what we'll do. We didn't know anything about the pandemic.
Yeah.
And then, people stepped forward, but having something that directs an emergency response team to begin to focus on this is probably the best thing to do.
That was my thought.
Yeah, you're right.
As I
You're
walked out, I
absolutely right.
drafted something to 2 people to get comments. I don't know, what is this testimony? I don't know, they're probably going to die that I sent them anything. To be fair, I talked to people before I did anything, just to make sure they thought, is this an idea worth I could be helpful on thinking about it. I think the other thing is you do other work groups. We have, what's the work group of where the money could come from? That's, how do you keep what's required to backstop Blue Cross if they suddenly become vulnerable? be a part of that, where could that money come from? That's what you want. People who know finance, they say here, our hospitals have, many of them are sitting on big balance sheets.
And how do you have processes that get the money to where it needs to go? So it's one thing to know where it is, and then we need to have ways to actually move the money. So
Yeah.
I think
Well,
that's
so that is an issue. So, and what is it, at what level is an emergency? So you could have an emergency for a critical care hospital and you say, oh, well, the money is over here. It's an emergency. But what we're specifically looking at is we have a federal emergency. What's coming out of Washington and how to frame that. So we're not seeing an emergency in a local clinic that's driving something, but it could. It's gets
I
complicated.
agree,
Yeah.
this is non-trivial. It's not as simple as getting vaccines or ICU beds or ventilators to somebody. But I think it's the idea of looking at the options and then saying which is the most feasible and who could do what to make it happen. I don't know. It may be that, whoever's on that team says, well, the only way we're going to fix this is an emergency piece of legislation that says we're going to do this because we just don't want our Vermont population, this particular community to be hurt too badly. And maybe there's not reserves anywhere else or, it's liquid enough to move there. So I didn't pretend to know what the answers were. I just thought it's worth thinking about how we define the answers.
Well, it would be helpful, I think. I'm always hesitant when it's an emergency and you have an agency and a regulatory board and an executive branch that needs to respond quickly to interject something that's going to slow it down. On the other hand, to at least recognize that this has happened before, and so maybe we should say something about it in statute, at least session law.
Yeah, that's an interesting idea.
Yeah.
I think the other thing that we all talked about in the informal conversations was the importance of engaging the state health systems as partners in finding, in helping solve this. And I thought both Dartmouth and UVM should be involved as part of that little planning, even an informal planning group to talk about it.
So, is it the informal planning group, or we put something in statute that makes it happen, or is it organic? And I know there's a lot of organic stuff going on right now outside of this building that is helping us with our work. So
I would guess if the powers that be in the governor's office and AHS and the Green Mountain Board of VFR said it would really help if you would do this. Then maybe what? Elena.
It just looked like you wanted to say something, maybe.
Oh no, I was probably about to sneeze. No, but I agree. I agree that it's helpful for people to feel empowered to step up and do this and to have some thought about who needs to be at the table is important.
yeah.
And I forgot to mention primary care.
Hello.
Being present in that little planning group.
Yes. Okay. Nothing like a challenge. So thank you. We're not finished yet. So we're going to be talking about trying to get some language on the table, and I'm going to talk with the committee for a few minutes. So we'll go with that. We've got like 6 minutes. I just want to talk process with the committee. And so we're gonna go offline for that, and then what we're